Morning, everyone. My name is Stefan Pauluzo, and I'm the Central South Regional Stroke Program Director. I'm very happy to welcome you all to this morning's webinar about the TIA decision-making rule. This webinar will be recorded and posted on the Central South Regional Stroke website shortly after the completion of today's event. I'll post the link to the website in the chat during the meeting today. I'd like to take this opportunity to thank all those involved in the planning of today's webinar, and in particular, Dr. Jeff Perry and Dr. Mike Sharma, who are presenting today. Dr. Jeff Perry is a professor and vice chair in Research and Scholarship Department of Emergency Medicine and a senior scientist at the Ottawa Hospital Research Institute. He is a research chair in emergency neurological research at the University of Ottawa and an emergency physician at the Ottawa Hospital. Dr. Mike Sharma is the Central South Regional Stroke Medical Director. He is the Michael G. DeGroot Chair in Stroke Prevention at McMaster University and a stroke neurologist at Hamilton Health Sciences. The objectives for today's webinar are to understand the background as to why there is a need for a TIA decision rule, to introduce the region to the rule, to understand the process that was undertaken to develop the rule, and to discuss practical implementation and utilization issues. There'll be opportunity for questions and discussions at the end of the webinar, so please, and actually a couple points through the webinar as well, we'll have opportunity for some questions as well. So please submit your questions through the Q&A function at the bottom of the screen. With that being said, I'd like to welcome you to today's webinar, and I'll hand it to Dr. Sharma to get us started.
Thanks very much, Steph, and thank you everyone for joining us. I'm going to go through the introduction and then hand it over to Jeff Perry, colleague and collaborator. Transient ischemic attacks are relatively common. This data is from the US, but about 2% of the entire population, which means 5 million, have experienced a TIA. And as you get older, much more likely. So 1 in every 15 over the age of 65. It's almost certainly an underestimate. We do know that there are a number of people who have symptoms, but don't seek medical attention as they are transient. There are also times, of course, when symptoms occur, when there's no one else around, that they're not noticed. For instance, facial asymmetry might not be noticed if you're alone, or speech difficulties, again, if you're alone. Our whole thinking on what to do with TIA changed about 20 years ago. This is the graph that was published from the Kaiser Permanente data in San Francisco by Clay Johnson, looking at the natural history of patients with TIA from the EDs in the Kaiser Permanente system. And what this showed was a huge drop-off in the very early part of the time period, showing strokes occurring very early and an absolute risk of stroke in 90 days of 10%. So two things is brought up. First, that the risk that occurred within 90 days was very high, and double-digit risk of stroke. And second, that half of these occurred within 48 hours. Now, this was some of the data that was used to derive the ABCD2 score. And one of the things I want to point out, and Jeff will go into this in more detail, is that data is now over 20 years old. So, one of the reasons we might think we need a new way of classifying risk in these patients is that a lot has changed since then. Now, that data was from the US, and I think when we first looked at it, we wondered if it had to do with the systems, with the issues of primary care in the US. And so it was published again from Canadian data. This is specifically from Ontario. David Gladstone did this in 2004. And at that point in time, our 90-day rate was 9%. So again, very similar to what was recorded in San Francisco. And you see that very steep rise in the occurrence of stroke in the first 48 hours. So about half of them generally occur within 48 hours of occurrence of the TIA. So, if you think about short-term prognosis for patients diagnosed with TIA in the ED, and what we know or knew at that point was about 10% will have a stroke within 90 days, and about half that within 48 hours. Another 12% or so will have a recurrent TIA. Now you'll see shortly that those TIAs occur more often later in the time period, but that's another visit to the ED. And a smaller proportion will have another event, such as an MI, and a few percent will experience mortality during that 90-day period. The risk totally of events occurring in this population in that time period is 25%. So looking at this, we knew that we had to do something to prevent all of these early events. One of the initial publications we had demonstrating the efficacy of a system change was this one, but this has occurred now everywhere. This isn't a particularly unique change that we made. This was published when we were in Ottawa, but everywhere across the region, across the province, you now have urgent referral processes set up just to deal with that early risk. And depending on your capacity, they have to be stratified in some way, usually by the risk of occurrence of stroke. We don't have the capacity to admit everyone, though there are certain systems in the world where exactly that happens. In Germany, for instance, my colleagues are aghast that we don't admit all our TIAs because they do, due to this increased early risk. There are other systems, Toronto Western has one where it's a day hospital where they go from the ED to sort of a holding area where they stay for the day and are investigated and seen at that point. And then for most of us, there's some ability to stratify based on risk. Now, what we did there was we looked at our risk of stroke occurring prior to a system change, and that system change was rapid referral from the ED, along with very rapid investigation. And then we looked at what happened afterwards. In about 1,000 patients that had flown through our ED, our predicted risk of stroke by 90 days was 9.1%. So bang on what it was in Ontario. The measured risk after we made all the system changes was 3.2%. So simply by reorganizing the system, moving very quickly and targeting what we thought were the high-risk patients at that time, we had reduced the occurrence of stroke from a predicted 9% to 3%. So 2/3 of those events didn't occur. So stratification, sorting out which patients do need urgent attention and rapid evaluation can be very effective at reducing stroke rates. Now, 3% still is something we're working on, but this is how effective a system change can be. And that led us to sorting out the best way to stratify patients and the Canadian TIA score. At this point, I'm going to switch over and let Jeff take on the story of how this score came about, how it was derived, and what it looks like. Jeff.
Thanks, Mike. So we'll just pull this up here and full screen. Great. All right, so thank you, Mike. So the Canadian TIA score, just going to go through a bit about where it came from and explain a little bit of the science behind it and how to utilize it going forward. First off, I don't have any relationships with any profit or not for-profit organizations. I do get a salary support through an unrestricted peer-reviewed mid-career salary support grant from the Heart and Stroke Foundation of Ontario. So the purpose of this Canadian TIA score is really to identify who is at high risk and who's at low risk, essentially, following a TIA or a non-disabling stroke. So somebody who could potentially go home. This follows a quite a long series of studies that we've been working on to try and evaluate the best way to triage or optimally manage all the patients within the system. I would like to highlight a few of these studies, which is where we previously validated the ABCD2 score, which I'm going to talk about in a minute. We then derived the TIA score in nearly 4,000 patients. We then looked and surveyed both neurologists in Canada as well as emergency physicians across Canada to determine would they actually have any faith in the proposed score And would they use such a score? And also, very importantly, at what threshold would they consider somebody to be low risk versus medium risk and high risk? And then most recently, which I'm going to focus most of the time on, is where earlier this year we published the validation of the Canadian TIA score in a set of new patients of over 7,000 TIA patients. So the prospective validation of the ABCD2 score was a very important paper. We published this back in 2011, but this was actually the first time that the ABCD2 score was prospectively validated. Where Dr. Sharma was indicating, much of the ABCD2 was generated in that important work from California. However, all this work was actually retrospective, and it was sort of database driven rather than being prospective, where you could really clearly define and look at as many variables and investigations as you want to, as well as prospectively making sure that you have all the right outcomes. So that wasn't done, which was one of the initial thoughts that that the ABCD2 may not be quite as strong as it was first cut out to be. And indeed, we did find that using their high-risk criteria, it was only 31.6% sensitive for stroke at 7 days. If you use the other threshold that was being promoted at the time, which was 2 by the American Heart Association, it did improve its sensitivity. It was able to identify almost 95% of all the subsequent strokes at 7 days. However, almost all patients were deemed to be high risk, with a specificity of just 12.5%. So almost everyone was uniformly high risk, so it didn't really help you triage. So this led us to continue on, and as I said, in a cohort of almost 4,000 patients, we've prospectively generated a clinical decision score to help identify what the risk is for subsequent stroke. And we identified 13 variables. It wasn't terribly surprising to us that we had a more complex rule, given that TIA in stroke is not a uniform disease. There's several different causes of it, and so it's not surprising that say the patients with large vessel disease, cardioembolic or small vessel disease, that these patients are going to have potentially different clinical findings, and they may be a bit more complex than the ABCD2 rule. So I will spend just a couple of minutes just saying what these variables are, because they have stayed the same throughout the validation. So the first TIA in their life is important. If their symptoms last for 10 minutes or longer, that too is important. If they have a past history of carotid stenosis, so they're known to have carotid stenosis on some imaging in the past, if they're already on an antiplatelet agent, if they report a gait disturbance as part of their event, if they have unilateral weakness, that too is predictive. And history of vertigo, importantly, is a negative predictor, a quite strong one, but it will get overruled if patients have other symptoms. So patients with isolated vertigo are going to be at a very low score, but if they have vertigo along with other symptoms, they may indeed have a higher score. Initial elevation of diastolic blood pressure, if they have speech disturbances, either dysarthria or slurred speech, or aphasia where they're having word finding. Then we also looked at investigations. So if they're in atrial fibrillation, if they had an infarct seen on their CT imaging, either an old or new infarct. And then we also found that elevation in platelets, indicative of a hypercoagulable state, or glucose being over 15, likely representing uncontrolled diabetes, that this was quite important. So patients can have a total score of anywhere between -3 up to 23 in theory, although in the studies, I don't think we ever had anybody with more than about 15, 16. So once we created the rule, or the score rather, we then sought to get feedback from emergency physicians and neurologists to try and figure out would they actually you have faith in this kind of score, and would they potentially use it? And also, very importantly, what would they deem a low, medium, high risk patient? And essentially, we found that this is for the emergency physicians report, and they were they thought that each of these variables was either very important or important clinically, their clinical impression. The ones with the least amount were the elevation in blood pressure, the elevated platelets, and the elevated glucose. Interestingly, the neurologist also had the lowest for these, but these were certainly all above 50%. These last two, they did have more faith in those variables than the emergency physicians did, but they do make clinical sense. And then finally, at the bottom here, not about 96% said that they would use a well-validated score. They defined low risk as being a 7-day subsequent stroke risk of less than 1%, medium risk of 1 to 4.9%, and high risk as being 5 to 10%, and then really high risk at over 10%. So we did conclude they would likely use the rule score. They did have faith in most of the variables, and they did define the low risk as being less than 1%, medium 1 to 4.9%, and high risk for being greater than 5%. So we then went on to validate prospectively the Canadian TIA score. So the objective of this study again was to prospectively validate the score in a new cohort of emergency department patients with TIA or non-disabling stroke. So patients that could go home with their stroke. This was a prospective cohort study. It's done at 13 high volume urban sites across Canada. And some of these were academic, some of them were community hospitals. And we had all components of the Canadian TIA score, as well as the ABCD2I score collected individually and as a whole, as well as their investigations and admissions. Our primary outcome for this study was subsequent stroke or carotid revascularization within 7 days. In contrast to our original derivation study where we looked at only subsequent stroke within 7 days, in this one we did include the carotid revascularization as well. Because we changed things, we did have a secondary outcome where we still looked at that original outcome, and I'll explain more about that in some subsequent slides. We looked at the interval likelihood ratios, and we planned for at least 5,000 patients, with at least 93 patients with our secondary outcome of subsequent stroke alone. So we included the carotid revascularizations because this work came out from Rothwell and colleagues, where they showed that your number needed to treat, if you had a carotid stenosis of 70 to 99% that was responsible for the inciting TIA or small stroke, that you'd only need to treat 3 people within the first 2 weeks to prevent a subsequent event. So we felt that not including early revascularization would lead to significant misclassification, where you may have had somebody with a critical carotid stenosis being deemed low risk, which clearly would not be acceptable. So we identified 9,400 patients throughout the study period at all sites, of which 7,600 were enrolled, and we had 183 with subsequent events. Of note, we only lost 34 of these patients to follow-up, which is very, very good. Our subsequent stroke rates, in contrast to what Mike was just showing you of almost 4% at 90 days, our subsequent event rate at 7 days was 2.4, and subsequent stroke or revascularization by 90 days was still at about 4.4%. Diving a little deeper, if you look at this column here, deems people gives you the information for the low risk patients, so that's less than 1% subsequent stroke risk, versus the medium risk versus the high risk as predicted by the Canadian TIA score. And based on their outcomes. So of the 183 patients, there were 6 patients in the low risk group and 53 in the high risk group. If you look at just the subsequent stroke rate, we found that half of those early risk patients were those with a subsequent early stroke, the other half were early revascularization. And then if you look at and then if you look at the admission rates, that's the other thing I want to just highlight, that about 5.8% of the patients in this cohort were actually admitted to hospital during that index visit. So when we look at the classification of these patients, so a score of -3 to 3 was deemed to be low risk with a subsequent stroke risk of less than 1%. And here there's just the 6 patients, 3 with the early stroke, 3 with the early carotid revascularization. Most patients fell into this medium risk group, and then this very important high risk group where they're at very high risk of subsequent early event. In terms of our likelihood ratios or interval likelihood ratios, we did find the low risk patients had a quite low interval likelihood ratio versus an elevated risk for the high. And these results were nearly identical for looking at our main outcome at the top here versus our secondary outcome of subsequent stroke, irregardless of their carotid revascularization down below. When we compared our tool to the ABCD2 or the ABCD2I, we found that our tool did outperform these 2 scores based on their C statistic. And we did do statistical tests using something called the DeLong method to compare the C statistic of the various scores. And these were very statistically significantly better with the Canadian TIA score. We further looked at how the C statistic, which tells you sort of overall sensitivity specificity, it's better. It seems to be better, or it is better with good statistical significance. We went further to look at, okay, well, how well do we actually reclassify patients into either low, medium, or high risk? And we found that the Canadian TIA score was able to better classify or improve the classification of over 12% of the patients, with almost 20% being reclassified. So it certainly performed much better than the ABCD2. And when looking at the ABCD2I, again, nearly 9% were reclassified favorably. So from this, we can now say that the Canadian TIA score accurately identified the risk of TIA patients' risk for subsequent stroke revascularization within 7 days. It did outperform both the ABCD2 and the ABCD2I scores and is ready to be used and safe to use. Individual healthcare systems can make specific thresholds to make management decisions. So we've used the survey results to inform what we think are probably the best for Canadian context, but there is certainly an ability to use the Canadian TIA score at different point thresholds that can direct care in a nuanced way locally. Now, how can it actually be used? So an example of how it could be used is that low-risk patients could be safely discharged following a careful neurological exam, lab work, ECG, and a CT, and then get more routine follow-up. That can, and starting obviously an appropriate antithrombotic agent. Moderate risk patients could undergo additional testing in the MERGE. So in specifically having vascular imaging, looking at their neck and brain, and imaging from getting a CTA to look from the aorta up to the brain to basically look for those critical carotid stenosis or other etiologies that would have more nuanced care. And then they'd still likely go home with early specialist follow-up. The high-risk patients probably should be fully investigated, managed right away, and likely a call to a stroke specialist during that index ED visit. Just those people are really high risk, and we need to do everything we can immediately if it's going to have any effect. So in conclusion, Canadian TIA score identifies the risk of TIA patients for subsequent stroke or carotid revascularization within 7 days. As it's anticipated that the Canadian TIA score will optimize resources, improve decisions on hospitalization, investigations, and prioritization for specialist consultation. Again, just showing you the point scores here. You may want to take a picture, or you can come back and look at it. Also, make note of the Ottawa Rules app. This app does have, it's free download, and does have the Canadian TIA score on it, because it obviously is too complex to keep everything straight in your mind, but it is very easy to use on the app. So thank you for this, and I'll turn things over back to Dr. Sharma.
Thanks very much, Jeff, for that nice overview. A lot of work there, many years of development. I think that when you and I first chatted about this, my hair was less gray than it is now. One question while people are revving up their question engine for you. And the question is this, Jeff. So in this rule, we've included as endpoints both stroke, which we care about, but also carotid revascularization. So what's the justification for putting the two together?
Yeah, again, so given that the number needed to treat for critical carotid stenosis, so 70% to 99%, is just 3 within 2 weeks. And it's likely even less than that if you're treating it within 7 days. We'd end up, again, calling people low risk if we didn't include them and actually cured their disease and prevented a subsequent outcome. And given that it is so effective at preventing a subsequent stroke or death, it certainly would confound our results and make us calling somebody a low risk when they truly are one of the highest risk patients out there. We didn't include atrial fibrillation and starting anticoagulation, just because although very effective, it's not to the degree and the carotid revascularization is, and it takes a lot more time to get things that prevention's to be effective.
Yeah, thanks, Jeff. So, it's almost as if carotid revascularization is a prevented stroke that would have occurred otherwise. Not many treatments have a number needed to treat of 3. There was a question about the name of the app. Would you mind sharing that again with everyone?
Yeah, so it's the Ottawa Rules app, and it's available for both Apple or Android, and it's, like I said, free download, fairly simple to use.
Great. There's a suggestion to put it on MD Calc as well. So yeah, there's that. So thanks very much, Jeff. While there's Steph, are there other questions you wanted to get to?
Yeah, Dr. Sharma, there's just a couple. And so the first question is, if a complete TIA workup is possible in the ED for every moderate and high risk patient, and if indicated, vascular consult can also happen if indicated on the ER index visit, what is the added benefit of an admission?
Sure, I'm happy to address that. So it's a good question. If you can get everything done there, can you discharge the patient? The issue is even with everything done, there is a risk of stroke occurrence. So the added benefit has been felt to be the availability of rapid acute treatment, thrombolysis or EVT if a stroke occurs. Now that is nuanced. So there are times when we have a patient in the ED that we look at, we've got vascular imaging done, if things are organized, we've done a consult and started them on treatment. If they are close by, if they have someone with them who's reliable, and if they've been instructed in what to do when a stroke occurs, which is called the ambulance right away, then sometimes we're comfortable letting them go home. When those things aren't there, I prefer to keep them. When that stroke occurs, then we can be on it much more quickly than if they're by themselves at home unable to get help.
Let's start to Sharma.
Mhm.
There's one more quick question here. Thanks for the great talk. For those at low risk versus medium risk, how quickly is an acceptable time to be seen as an outpatient in follow-up? And this person asking the question says that their center currently has follow-up at the secondary prevention clinic of 3 to 4 weeks at the moment. So what's an acceptable time in terms of getting them into outpatients?
Okay, well, let me ask Jeff his thoughts as an ER doc. So Jeff, if you've got somebody medium risk with a 4-week wait, how comfortable are you? And then I'll give my thoughts.
With the 4-week wait for medium risk, I'm not comfortable.
Yeah.
I think that's just way too long. The low risk are probably fine, quite frankly, with that kind of a wait. And that is one of that's not a unique situation. These extended wait times are true in many places across the country, and that's one of the reasons why we are promoting the use of the Canadian TIA scores to better care for our patients despite these longer waits, and deferring the care for the low risk patients while expediting the medium risk would be highly appropriate to prevent subsequent stroke.
Yeah, I think that's great. So in terms of level of comfort for medium risk, I'd say that really you want to get people seen within 48 hours. That's what we target. We don't always meet it. And you're right, there are resource issues everywhere, but 4 weeks I think is very long. Low risk, yes. And the other ones where 4 weeks entirely acceptable are the ones where the diagnosis of TIA is questioned. So you may have somebody who's got transient global amnesia, or you're wondering if it's a TIA at all. That time frame I think is acceptable for those sorts of marginal cases, but medium risk I would be uncomfortable with that. Any other questions, Steph?
There are 2 more actually. Maybe we can do these last 2 and then we'll finish up the remaining slides and then open up for further discussion if that's okay. The first question is there evidence that rapid response time and recognition of stroke is better for inpatients versus outpatient TIA?
So I'm not sure I fully understand that. Can you read it again?
Yeah, is there evidence that rapid response time recognition of stroke is better for inpatients versus outpatient TIA?
Right. So, in terms of response time, what we know for acute stroke in terms of thrombolysis or EVT is there's a direct linear relationship between onset time and to treatment time and outcome. So minutes matter. Each minute you lose about 2 million neurons. Now, if you think about what the process involves as an outpatient, there is the delay of recognition of symptoms, of calling EMS, of transport, and that portion is shortened in hospital. I will tell you that it does require your hospital system. So when these patients are admitted, that somebody does do neurovitals on them and the change is recognized. So if it's the case that they're left to sleep for 8 hours, then you may not recognize it very quickly. So with the caveat that you need to have enough nursing staff, you need to be able to do the neurovitals. Inpatient response times are going to be quicker generally than outpatient ones. And I've given you the scenario before where patients who live not far from the hospital, reliable family members, they understand those patients. I think it's reasonable that they go home, they're well instructed, and they come back if symptoms recur.
Perfect, thank you. Maybe one final question before we get back to finishing up our slides. Do we have to place a patient on double anticoagulants while waiting to be seen at the stroke clinic?
So it's a great question and a great segue into the second part of the talk where I was going to touch exactly on that, is the use of dual. I think the questioner meant dual antiplatelets rather than anticoagulants. And so with your indulgence, I'll go through the remaining and we'll touch on that. And by the way, if I don't answer it to your satisfaction, please ask it again. So look, in terms of the practical issues, some of these we've touched on, you need to have it available at the point of care. For me, I can no longer keep track of all the little pieces of paper I need So anything on the phone is much better, and I'd encourage you to use the app. And I think Jeff, it'd be good to get a hold of MD Calc and see if they'll put that up there. The other really important part, which I think a number of the questions have really gotten to, is the stratification in terms of risk doesn't do the job. It needs to be connected to a system of care, and you need to look at the options. One option is hospital admission, and for those at high risk or where you're going to be very delayed in getting investigations done, admission may well be the best option. The second is a rapid outpatient process. When our clinic here is firing on all cylinders, we get the patients the next day. So they're referred by our ED, and then we get to them the next day. It's not uncommon for us to go to 48 hours and occasionally a bit longer over holidays and things like that. But that really needs to be done very quickly. One way around it, if your outpatient process is slow or delayed, and it will be in a lot of places, is to then do the investigations in the ED to identify those high-risk carotids in particular and deal with those very quickly. The whole goal of this process is to get to the cause of the stroke and specific treatment. And really, when we're thinking acutely, there are a couple of things to think about. Antithrombotics, the antiplatelets that the questioner asked, anticoagulation for atrial fibrillation, identifying those early. By the way, so just as a number to remember, when you see a TIA, of all TIAs, the chance that they'll have atrial fibrillation is somewhere between 6 and 10%, higher as people get older, and it may be the first diagnosis of AF. And then really important to get at symptomatic carotid stenosis so they can be referred for evaluation and if suitable, endarterectomy or stenting. Now, the Canadian stroke best practice guidelines lay out timelines and expectations and treatment. This was a 2018 update. There's also a 2020 update, which is all available online. I'm just going to go through some of it. So one, in terms of diagnosis, it lays out the blood work that needs to be done. I think in most of our IDs, this has been integrated. Everyone needs a 12-lead ECG. Everyone should have brain imaging, CT or MRI. Now for vascular imaging, the preferred investigation is CT angiography or MR angiography, for the reason that it is more specific and more comprehensive than carotid ultrasound. Carotid ultrasound looks only at a very short segment in the neck and may well miss things like dissections, which are sometimes hard to see on ultrasound and may occur at a proximal or distal to the area that's insunated. It also does require, if you're relying on carotid ultrasound, it's very operator dependent. So it requires a CQI process to make sure that the ultrasounds are reliable. I know that CTA isn't accessible everywhere very rapidly, but do know that as time goes on, it's going to become more and more the standard of care. In this version of the guidelines, it did allow for carotid ultrasound if you look at D, if CTA or MRA is not available. In terms of timing, this version of the guidelines was before publication of the score, so it's based mainly on time and somewhat on symptoms, but basically you want to deal with things very quickly if the TIAs happen urgently. The highest category here is for symptoms in the last 48 hours. There's a separate category for 48 hours to 2 weeks, and then more than 2 weeks ago. But just remember, if it's happened very recently, you want to move quickly. Those are the ones who are on that very steep portion of the curve and are likely to have a stroke in the next hours to a day or so. To get to the issues of initial therapy, and this is going to become, unfortunately, a bit more complex. So I'll tell you what evidence we have currently and where we use it. So the guidelines say that antiplatelet therapy should begin as soon as possible after brain imaging, within 24 hours, and ideally within 12 hours of onset of symptoms. For high-risk TIA or minor stroke, now, minor stroke is classified as an NIH score of 3 or less. We have 2 separate trials supporting dual antiplatelet therapy, aspirin and clopidogrel, for 21 days. So if you have a TIA, which is high risk, or a minor stroke, which has minor deficits left, aspirin and clopidogrel should be started. There is a load of aspirin we usually use if we're going to do that, 160, and a load of clopidogrel, 300 or 600 milligrams. In our practice, we use 300 milligrams. One trial, which was Chance, used 300, Point used 600 milligrams. The benefit was about the same. There wasn't a difference in hemorrhagic risk there. So we tend to use 300 milligrams, which works just as well. By the way, don't skip the loading dose of clopidogrel. If you skip it, it takes about 3 days for it to be effective, which is right during the high risk period for the TIA. Emerging is aspirin and clopidogrel. So both ticagrelor. Both ticagrelor and clopidogrel are PY12 inhibitors. Ticagrelor does not need to be metabolized and is reversible, so theoretically has some advantages. There are a proportion of people, maybe 25% or so, who don't metabolize clopidogrel well. So when these guidelines were written, one trial had shown benefit of aspirin and ticagrelor. We now have a second trial that was just published called Chance 2, which was done in China, specifically in people who had a loss of function allele. So they didn't metabolize clopidogrel, and then they were randomized to ticagrelor or monotherapy. Aspirin and ticagrelor is a benefit, better than aspirin for stroke prevention. I'm not sure if it'll become first line, just for the reason that it's associated with a higher risk of hemorrhage than aspirin and clopidogrel, and may be of greatest benefit in people who can metabolize clopidogrel. So it's going to be a little bit of a conversation to decide whether that becomes second line or first line, or whether we put in point of care genetic testing for that. Everyone who doesn't meet criteria for dual antiplatelet therapy should have monotherapy. By the way, sometimes there's a concern I hear expressed from my colleagues in ED that they don't want to use dual antiplatelet therapy if it turns out not to be a TIA or not high risk. But if your system is operating along the timelines that we've described, 1 or 2 days of aspirin and clopidogrel, I don't think will do any harm. And once the patient is seen, if it turns out that they don't meet criteria, the clopidogrel can be stopped. Very important, by the way, when you start it, to make sure it goes only 21 days. Longer treatment seems to be associated with more hemorrhage without benefit. Oral anticoagulants are the other ones that are important. So if you've got somebody with a TIA or minor stroke, and you diagnose atrial fibrillation on the ECG, which they should all have, when do you start it? So this is the CCS guidelines. Again, they're available online. And I just want to point out that for TIA, oral anticoagulation can be considered within 24 hours of TIA onset. So I think if the CT scan is completely normal, the examination is normal, symptoms have resolved, then you don't need to wait. If it's a mild stroke, then that patient probably should wait about 3 days or so. And there are a number of criteria which may adjust these timelines. So, I think for TIA, that can be started right away. Strokes should be admitted. So one rule that we've always had is if there's an infarct there on CT or lingering symptoms, you think it's a stroke, you should admit those patients. Are at much higher risk, and may deteriorate very early. Right. So this is just a summary slide. Jeff has gone through the advantages of using it, and if you don't use it, then you're really relying on some variability in practice. This gives you an objective way to make that stratification error. It's designed specifically for use in the ED and uses all the features that are available. And like with all rules, very uncommon scenarios, you have to use your clinical judgment. So traumatic dissection, COVID-19, which we know increases the risk of stroke, congenital heart disease, pregnancy, a number of other things that you should think about there. I'm going to pause there, and Steph, I'm going to turn it over to you to see if there are other questions that we can help with.
Thank you very much. Yes, there are a few more questions that have come through. So first question is, would secondary prevention clinics like the Canadian TIA score done on every patient to help them triage them?
So that's a really good question. And I think it depends very much on what the process is. If the timeline is long, so if you're working in a place where the timeline is weeks, I think it'd be very helpful. You do want to talk to the clinic and make sure that's integrated so that they'll see patients who are higher risk earlier. It should help them. I personally think when our timeline gets long, we may need to use something like that, but our focus has been on seeing people very quickly.
Perfect. Thank you. Next question about imaging in the ED. What imaging should be completed and resulted in the ED prior to allowing the patient to go home? Some of our EDs have typically done CT while the patient is in the ED, but sent the patient to ultrasound as an outpatient.
So, I think that if they're high risk, they should definitely have vascular imaging in the ED. CT angiography is what we favor there. And medium risk patients, if they're going to have a wait, should have some imaging done in the ED or very quickly within 24 hours. If it's the case that you're using ultrasound, what you have to remember is that the ultrasound may not occur for days and they may not be evaluated. Consider a weekend or a Friday, you put the requisition in, it's not going to happen on the weekend, they won't be seen. So those are patients who probably should have vascular imaging if they're medium or high risk in the ED.
And Steph, just for clarification, the lower risk patients, that probably is a sound approach, but it's the medium and high risk that we really need to know what's going on with the vasculature in a time sensitive way.
Okay. Perfect. Thank you. Next question. It's a follow-up question for the admitted TIA patients. Are these patients, as in when they're admitted, are they waking up overnight for neurovitals? And what's the frequency of neurovitals being done for admitted TIA patients?
So if you're going to admit them, then I do think you need to do the neurovitals frequently. Probably somewhere like 3 hours is a good frequency to do it. You're still within a good window in terms of thrombolysis to act quickly if that's the case. So when you admit them, make sure that somebody keeps an eye on them. They're in a place where they can be seen. When they're awake, it's relatively easy, but when they're asleep, probably 3 hours at maximum.
And for the smaller sites, it's extremely important that the nurses know to inform the doctors right away if there are neurological deficits, even if they're perhaps not necessarily major, because they warrant a closer exam and closer assessment to make sure that there isn't something more significant going on.
That's a very good point, Jeff. By the way, do you have a special process in the ED for TIA patients while they're waiting?
So while they're waiting, we don't have a specific one, but where we are, they don't tend to wait they wait, sorry, I shouldn't say that. They wait a long time to get seen by the emergency physician sometimes inappropriately. If their deficits have resolved, they are instructed to come forward and say if things get worse, but they don't, once they see the physician, it's most times they're fully sort of assessed within about 3 to 4 hours. So probably within that time period. So we don't have a specific system in place locally, but they can wait sometimes 12 hours to get seen, which is crazy, but unfortunately a reality in locally in our emerge.
Okay.
Perfect. Next question, and this is, I think, a follow-up to treatment for the patient being discharged. What if the patient's already on a treatment like daily aspirin?
Okay. So it's not an uncommon scenario where they're already on an antiplatelet. So those patients, you would look at a couple of things. One is, do they meet criteria for dual antiplatelet therapy, and then make the addition there. Second is atrial fibrillation, in which case they should be switched to an anticoagulant. The anticoagulants do require follow-up, and you may want to contact somebody about that. But importantly, you want to think very carefully about doing carotid imaging quickly on that patient. So there's somebody already on an antiplatelet who's had an event, and if they're medium or high risk, my concern would be that they're harboring a tight carotid stenosis and need prompt attention for that.
And Mike, maybe if I could just add a clarification too for the dual antiplatelets. So remember, we said that these are for high-risk patients. In the CHANCE and the POINT studies, they used the ABCD2 score of 4 or greater to define high risk in both their TIA and then their minor stroke. As we've pointed out, the ABCD2 score is not great. Certainly, I'd say that translates into certainly anyone who's in medium or high risk patient should be started on dual antiplatelets or anticoagulants, whatever is appropriate given their clinical situation. If they're in atrial fibrillation, start an anticoagulant. If they're otherwise, start dual antiplatelets if it's appropriate to. And then for low risk patients, I'd say the vast majority of them are probably okay with aspirin for the most part. But if you think they've had a subsequent event and they're already on aspirin, what do you suggest in that situation?
So excluding the tight carotid, what I tend to do is switch them to clopidogrel. And I think clopidogrel monotherapy is reasonable. We don't, people use this term aspirin failure. Do know that aspirin has an efficacy of about 20 to 25%. So it's not terribly effective. And I don't think we should call it failure. It's working as we know it does. But I think it's worthwhile making that switch over. If you switch over, load them with clopidogrel or overlap for 3 days to get that.
Fantastic. The next question is about process in rural EDs. So in the rural ED, for a higher risk TIA patient, is it acceptable to access advanced imaging like CTA or MRA and neuroconsult through the current hyperacute pathways, so utilizing critical?
Jeff, do you want to comment or?
I guess I'm not sure that it's appropriate through necessarily the critical pathway if the deficits have fully resolved. If they're having ongoing deficits, I think it probably would be appropriate to go through. But if the deficits have resolved, but yet they're still a high risk patient, I'm not sure. I'll let you maybe speak about whether do you go through critical. I think probably not. I think you would probably, though, you would definitely need to pick up the phone and communicate with a stroke neurologist or at least another tertiary care kind of emerge department to have the patient transferred for further assessment, including vascular imaging right away, because that patient should not be waiting to get through sort of a routine kind of mechanism. They do need to go on. I guess the question though is whether it would go through critical. That I'm less certain of. Maybe Mike, if you.
Sure. So Jeff, I think those are good points. This really speaks to the need to have a system. So what you want is to have a system in place for high-risk patients in your ED without having to create the system on the spot, which is what the critical call does. If here locally, if we had a call about a high-risk TIA at night, these are things that are usually handled in our ED. So generally be an ED to ED transfer. And with ED loads right now, I can tell you that our ED docs who have, and all the ED docs in the province who've borne the brunt of COVID and a number of other things, don't have the capacity to accommodate a lot of these requests. So the advice may be to keep the patient in overnight and expedite the transfer for imaging the next day. But even better is to think about your local situation and have the plan worked out beforehand of what we're going to do. One of the problems right now in the whole system is capacity. So I think critical is good if you're in an unusual situation to get advice, and sometimes that'll include imaging. But for cases like this, we don't really have the capacity to, on the fly, deal with these requests.
Yeah, certainly the best system, the best way forward would be to have a system in place where you can either, if it is, like you said, in the middle of the night, it may make sense to wait for the first thing in the morning, have the patient transferred over when they're more likely to get imaged quickly and not sort of tie up additional resources, but still not wait for days to get this critical imaging done. And if they're high risk, then they should be getting seen or at least some communication with a stroke specialist as well, if they're especially at high risk.
So, Steph, it sounds like a system issue for the regional stroke system to work through.
Certainly something to work through to set up a process.
Yeah.
Maybe one last question. I see it's 8:58 here. We're right up against 9 o'clock, and I'm sure everyone has to run. This question was sent through for Dr. Perry. What is the value for the VAN score in the emergency department, and do you utilize it? And at the end of your answer, if you're able just one more time to say the name of the app, that would be helpful as well.
Yeah, so I'll just say the app so I don't forget it. It's the Ottawa Rules app. And that's, again, so they don't sort of forget that. So in terms of the VAN score, looking for I believe they're talking more about large vessel occlusion. Is that what they're, we locally?
Yeah, I'm not sure what specifically they're asking about, just basically the overall value of the VAN score and if it's utilized in the ED. Yeah,
we don't utilize it locally. We do look at the LAM score for large vessel occlusion. That's the one that's being used by our stroke neurologists and us in the eMERGE. But it's basically for patients who are suspected of having sort of a large vessel occlusion, looking for EVT, so endovascular removal. Those patients, it is very important to be thinking about large vessel occlusion, especially if patients have ongoing deficits that are significant and felt to be, those patients need to be evaluated quickly by a stroke specialist and with full imaging, and this needs to still be done in a time sensitive way. The exact time cutoff is, I guess, under still research and development, but and more it's becoming now. Wake up strokes, people with deficits that are there for even 12 hours or longer are being evaluated for possible large vessel treatment with endovascular therapy. But this is an area that's still very much in evolution. Mike, did you have anything to add to that?
No, look, I think there are a number of scores out there. Basically, if you see a person with hemiplegia, aphasia, or neglect, which are the three things we look for, and they're beyond 6 hours, which is the usual window to trigger EVT, those are ones who should have advanced imaging. So we do a rapid scan, and if that's positive, our ED docs call us and we get moving on EVT. So it's a way of looking for these late window patients who have large vessel occlusion and may benefit.
Yeah, and that's something that's variable across the country. Like I said, we locally have a system in place where even patients that are up to 12 hours, if they have a positive LAM score, then we actually even activate a stroke code right off the get-go. But it's these because the evidence is still fairly small in terms of numbers, you're going to see a lot of variability in that after 6-hour window. Before 6 hours, it's pretty clear what to do. That after 6 hours, it's certainly in a state of evolution.
Wonderful. Well, I see that we're at time now. We're a couple minutes over, so I do want. There's many comments in the chat thanking you for such a great talk. I'd like to thank you very much, Dr. Sharma and Dr. Perry, for the excellent presentation and discussion. Lots of really great questions. This was a really helpful and very practical webinar in terms of utilization for the TIA patient. Again, to note, this webinar is recorded and will be posted on the Regional Stroke Network's website, csnstroke.ca, very shortly. On behalf of the Central South Regional Stroke Network, I'd like to thank all of you for attending the webinar this morning. We look forward to seeing you at future events. Thank you very much. I hope everyone has a wonderful day.
Thanks, Steph. Thanks, Jeff. Take care, everybody.
Bye, guys.
Bye-bye.